I'm seeing actually you are going to teach us about implant aesthetics. And first of all, actually you are talking about the risk assessment of the implant. So you're not talking about aesthetic first, but talking the risk assessment first. So actually we know there's more and more lecture right now. They teach how to dealing with the complications, especially some of the peri-implantitis, peri-implant mucositis. So what's your opinion and how do you do this risk assessment around implant aesthetic topics?
Okay, first of all, thank you again for the very kind words. You know, implant risk assessment is a very important topic. In fact, especially recognizing the problems that we're now seeing with many of the implants that we've done over the last 30 years. The way that the lecture is broken down is in 3 different categories. One is problems with lack of integration. That would be an implant that doesn't really integrate to begin with. The second one is loss of integration, which in some respects begins to touch on what peri-implantitis is or why we start experiencing marginal bone loss around seemingly healthy implants. Why do they tend to break down? And then the third is what we would call structural component failure. Screw loosening, fracture, porcelain breakage, the things that destroy the restoration, typically from some sort of load application. Now, what's really interesting is if you look at the first 2, lack of integration and loss of integration, there is much confusion as to what the etiologic reasons are for this problem. And one of the things I'm going to mention right now, which I believe will be very controversial, but I'll have a chance to describe it when I'm there, is that many people actually believe that occlusion is one of the main reasons for loss of integration. Yet the science does not show that very clearly. And so if we're really going to describe what the science says, it's different because on one hand, you see situations where implants are so overloaded they break, but they don't have bone loss. Why, in other situations, is that not happening? And so when we start to really understand the reasons for this, which we don't know all the answers, but what I feel is a big problem is many times when an implant fails, the person that gets blamed the most is always the restorative dentist. It's the restorative dentist that didn't properly manage the occlusion, or didn't properly manage the emergence profiles, or didn't manage the patient's access for oral hygiene. In other words, it's very easy to point the finger at the restorative dentist, and maybe that's not correct. In fact, we have to understand that there are reasons for implant failure, and they may be biologic ones that maybe a lot of people haven't understood as clearly as we should, and there are biomechanical loading problems that we have to understand because those are the things that we can minimize. There's no reason to see screws loosen. There's no reason to see some of the breakage and failures. And most of that, by the way, that I see are improper planning. I see too many problems with implants today that never should have occurred in the first place when you have proper patient selection, proper risk management. We have so many opportunities now to prevent all the horrific things that I see happening to people that it's really a problem. I have a lecture, and you'll see it when I come. I call it Patients with Ailing Teeth Transition to Ailing Implants. That shouldn't happen. And these are the things that are very significant. And for the patients that have to endure now the treatment, it's many times devastating to them. We can prevent this.
Thank you, John. Yeah.